Now, today we'll be discussing one of the very interesting topic, and that is cyanosis or peripheral arterial disease. So, this cyanosis is very commonly caused in this congenital heart disease also, but we will not be discussing this congenital heart diseases in this particular topic. So, what we can see in this photo is this area looks okay. The skin color looks okay. There is not much skin color change up to this area, and from above this area what we can see is, if we can see, there is hyperemia. The skin roots looks intensely reddish, pinkish, bluish. If we can see the nail, it is basically bluish. So this is definitely an indication that this toe or these fingers are getting cyanosed. We can see the color change here in the third toe, in the second toe, and this in the first toe also. There is a very well demarcation where this color change is there, which is not at all there here on this foot and up to this. What we can see is this color changes is getting started here. If you can see, see. This means that this patient has definitely significant peripheral arterial disease, and we'll be discussing what are the causes. And if you really want to make sure that this is definitely has a reduced blood flow, if if you want to definitely say that this has a reduced blood flow, or this is definitely getting cyanosed, or this patient is going to need amputation very soon if the problem is not sorted, or if the patient is not lucky enough. Now, if you want to diagnose that this patient definitely has a reduced blood flow, the most significant clinical things which are there are, there should be a color change. That is definitely one important thing. Now we can see here this, the patient has color change, means this patient has definitive peripheral significant vascular disease, because these all toes are almost cyanos, almost bluish. There is, this nail is very much significantly bluish, which suggests that there is cyanosis. Second thing is skin temperature. If this foot has no blood flow, actually this foot should be cold from around this area. So what you can see, you can simply put posterior aspect of your hand, and you can just compare the temperature of this skin, this skin, this skin, this skin, this skin, and this skin. And you can compare the temperature or warmth of this skin temperature to this leg as well. So if this is significantly colder, it definitely tells you that there is a vascular disease, significant reduced blood flow to the area. The third thing is, we can also check the uh, saturation of oxygen. So you can simply put the pulse oximeter on these sided toes, or these sided fingers, or these sided hand fingers, and you can put a pulse oximeter to this. So as there is already a color change, they are already cold, you will not be able to pick any saturation on these toes. And if you could pick it, it will be definitely lesser, maybe around 40, 30, or 60%. So it again definitely tells us there is that significantly reduction in the blood flow to these toes, which tells that there is definitely a significant peripheral arterial disease. Now the thing is what to do. Most of the time, these patients are diabetic. Most of the time, most of the time, these patients are tobacco addict. Maybe it is smoking or tobacco, but these are the two most important things which are almost there, which are always usually there. In absence of this, the patient may have significant hyperhomocystinemia, the patient may be purely vegetarian, or the patient may have any other cause. The patient may have autoimmune disorders, but most of the time it is always and always diabetes, or it will always and always will be tobacco, which causes this much of significant peripheral arterial disease. The second thing is what to do next if any of the such patient approach. We have to act very, 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 very fast, because if this problem is not sorted as soon as possible, within 24 to 36 hours, the patient may develop gangrene, and then patient will definitely need amputation if it is not sorted out. Now, what to do? The first and most important thing is the Doppler. Then you can actually do UEG Doppler of this leg, both the legs we can do, to see the internal iliac artery, to see the femoral artery, to see anterior tibial artery flow, to see posterior tibial artery flow, to see the popliteal artery flow. So we can see the blood flow, whether it is intact or not. And after that, to delineate all the arteries very, very well, we can do CT of bilateral lower limbs to, because it will show all the blood vessels which are draining, which the with the collaterals. Doppler cannot be able to see the collaterals, whereas CT angiography will not only tell us about the significant thrombosis, it will also very give us good idea about the atherosclerosis, the branches, the formation of collaterals, and the caliber of the vessels as well. So in these, most of the time, what we'll be able to see, there will be very commonly absent blood flow in one of the artery. It can be anterotibial, posterior tibial, popliteal, femoral, or there can be extensive vascular disease with presence of collateral circulation. So if that is the scenario, this anterotibial artery will not be visualized at all. So what it will appear, it will be like this. So you can see that this artery is very well opacified, and it's very well visible also. But in here, this artery has significantly narrowed. And this irregularity in the blood vessel indicates that there is atherosclerosis. Otherwise, if the artery is normal, the artery would appear straight like this. So if this artery appears this corrugated, then this means that this artery is damaged so many times over a period of years, which causes this damage and which causes this uh, corrugated nature. So in CT angiography, we can see all the arteries which are significantly impaired, if they are the arteries, the caliber, whether these arteries are well filled with contrast or not. Because if an artery is visible, well filled with contrast, means that artery is patent. Whether this artery is showing atherosclerotic changes, or they have corrugated nature, which suggests that there is chronic damage to the blood vessels. The narrowing of the arteries, and whether these arteries have very good collateral circulation or not. Because if this patient have good collateral circulation, the patient may have some time. But if the patient does not have collateral blood flow, these patients usually need amputation very, very fast, very, very early. So what we need to do once this is done, most of the time, a vascular surgeon or interventional radiologist, this come into the picture, and they do DSA, and most of the time there is either a graft which is placed in these blocked arteries, or the graft is placed around the blocked arteries, or a stenting is done across the blocked arteries where the mechanical thrombectomy is done. The clot which is present in the artery is mechanically damaged, mechanically removed. That is one thing done. Second thing is, he They can do the balloon dilatation of this artery to remove all the clot, to open up the artery. And the third thing which is done is putting a stent in these arteries so that this artery remains intact. So these are the things which are very commonly done. And when these all things are not possible, a bypass is very commonly done to to tunnel out if this is the artery which is significantly damaged, significantly calcified, very badly uh, blocked or blockly thrombosed, where it is not possible for us to do an intervention in this artery. A bypass is created to bypass the blood flow from the arteries and to give a better circulation at lower circulation. So, very commonly, this if larger arteries are involved, the intervention that can be done can be really good. But if smaller arteries or smaller vasculature uh, is involved, smaller vasculopathy is there, which involves only distal portion of the foot or ankle or leg, then the patient may have very bad prognosis and the patient may definitely need amputation. If this patient have larger vessel blockages or thrombosis, and if it is intervened very fast, then the patient may have excellent prognosis. If the patient have larger arteries, thrombosis like anterior tibial, posterior tibial, popliteal, femoral, and if it is not intervened, then definitely the patient may have very bad outcome. Most of the time, these patients usually need around 700 to 1000 unit of heparin that is continued for at least 24 to 36 hours. And then these patients are put on Clexane or enoxaparin in therapeutic dose twice a day till around 5 to 7 days till the patient is discharged. Most of the time, these patients are definitely given ecosprin. These patients are usually not put on dual antiplatelet like ecosprin plus clopidogrel. No, most of the time these patients are put on a single antiplatelet with the anticoagulant, which is usually heparin in earlier stage for around 2 to 3 days, then Clexane or enoxaparin or fondaparinux, and at the time of discharge, these are put on either most of the time rivaroxaban or apixaban or dabigatran or warf if the patient cannot afford these medicines. And the other drugs which are very commonly used in this peripheral artery disease is silastazole, pentoxifylline, and to treat the underlying cause like hyperhomocystinemia or vitamin B12, the respective treatment is needed. So I hope this topic gave us some good insight, and I'll be coming up with some other interesting topic. And thank you.